So I want to start out about HIV infection across time. There are preserved blood samples that were analyzed in 1998 that demonstrate that the earliest case of AIDS thus far documented occurred in Africa in 1959. That's a documented case. And it's now believed, based on the genetics of that case and how HIV has evolved over time, that HIV entered the human population in the 1920s and the 1930s. So much earlier than the way we think about it in the West. And it entered through the fact that HIV jumped at least 13 times from primates, we're primates too, from more hairy primates to us. And it did it on a variety of different occasions. And this slide just shows you that one of the jumps, which was to HIV-1M, was the most easily transmissible form of HIV. A lot of these jumps didn't result in epidemics because the virus wasn't strong enough to really create an epidemic. One of the reasons why I like to look at this is that I went to medical school at a time when we were taught that the one thing that medicine had done was conquer infectious diseases. So this is certainly not the case, and this isn't the last epidemic we're going to see. This is really an illustration of how new epidemics emerge. So after we've figured out how to master HIV, we'll be waiting for the next thing. So the timeline of HIV identification and treatment isn't the same as the actual presence of HIV, because the presence of HIV began in Africa a long time ago. But the first time it was written about was in 1981, when there were reports of gay men in the U.S. who developed very unusual conditions that you normally only saw in people with very suppressed viral load. Pneumocystis carinii, pneumonia, Kaposi sarcoma, and non-Hodgkin's lymphoma. And I'm sure that's what you saw at the beginning in Casey House, right? We all, at the beginning of the epidemic, experienced these sudden onsets of unusual illnesses that suggested immunosuppression, and we didn't know why. HIV wasn't isolated until 1984 by two people who went on to fight about who really isolated it first. And then the first diagnostic test was in 1985. And in 1986, there was the first household contact study. And the reason why that was important was it was a study that showed that HIV is not transmitted by casual contact. And that helped calm down the hysteria that existed at the beginning of the epidemic. And the first antiretroviral drug, zidovudine, was introduced in 1987. And now we have a lot of drugs. Our first successful combination was 1996. Now, even though by the time HIV began to really spread wildly in the current epicenter of HIV, which is sub-Saharan Africa, even though we had a good understanding of how HIV was spread and even how to prevent it, this did not have an impact on the way HIV took off in sub-Saharan Africa. So that's where the epicenter lies today. There's been 50 million people infected with HIV, and it's killed over 22 million people. We have the medicines to treat it, but we're trying to figure out a couple of things about HIV. One is, how do you get people to take those medicines consistently? Two, can you prevent HIV through vaccines? Or now we're talking about pre-exposure prophylaxis, right? PrEP. And three, can you cure HIV? And, we've been through phases and disappointments over cases that were reported to, result in cure of HIV, like the Mississippi baby, who in fact has now relapsed into HIV infection, trying to figure out how to cure it because HIV integrates into the human genome and it is extremely difficult to eradicate from the body. This is not discouraging people from trying to work on whether it can happen. So this is HIV across place. It doesn't show you North America, but it shows you Africa, where we've had the worst epidemic, South America, and Asia. And now if we look at the map of the world, basically those of us in the Americas, North and South America, have a moderate epidemic of HIV. We are not doing as well as Europe, Western Pacific, or the Eastern Mediterranean in terms of containing HIV, nor are we suffering in the way that some parts of Southeast Asia and certainly sub-Saharan Africa are. One of the things that's extraordinary about the HIV epidemic is the level of activism that led to thinking about health as a form of social justice. I can't think of another illness, and I've been doing this for a long time, that ever had the kind of activism that we saw with HIV and AIDS. And this resulted in a different awareness about HIV around the world and whether healthcare is distributed in a just way. So that activism led to a great deal of investment in antiretroviral rollout in sub-Saharan Africa and other poor countries. So you can see on this graph that until HIV came along, there was very little foreign investment in global health. The HIV epidemic totally changed that. So starting with UNAIDS in 1996, then the Gates Foundation, then the Global Fund for AIDS, Malaria, and TB, and PEPFAR led to an incredible investment, still not enough. And I think Canada has certainly made its share of investments through Health Canada and other initiatives here in trying to contain the epidemic throughout the world. What's remarkable is that if you think about sub-Saharan Africa, nobody responded to things like river blindness, which probably takes 1 penny of penicillin to prevent or cure. So it seemed very odd to start with antiretroviral medicine, which needs to be taken chronically, and even in its generic form is still very expensive. So it's really a lesson in activism. But what does that have to do with mental illness? What do primates, viruses, and spending money have to do with mental illness? And I can tell you that to this day, people will say, who don't really understand HIV very well, what does HIV have to do with mental illness? So, one of the famous early cases of HIV was a Canadian airline steward who was named Gitan Dugas, I don't know if I'm pronouncing his name right, from Montreal. And he was referred to in a US CDC study as patient 0, which was not an accurate portrayal of him because, in fact, HIV had entered the US long before this gentleman became a flight attendant. But what was true was that of the initial cases, 248 people who were known to be HIV infected in 1983. Now, in 1983, there was no HIV antibody test, so known to be HIV infected usually meant seriously medically ill. That was when diagnosis was made. So of those medically ill people who were known in 1983, 40 of them had either had sex with this gentleman or they had had sex with someone who had had sex with him. And the reason why I'm showing you this case is because it's illustrative of how HIV has spread in most of the world, not sub-Saharan Africa, but in most of the world, and that is that it has occurred primarily in racial, ethnic, and sexual minority groups whose disadvantages are linked to elevated rates of mental illness. And that's how mental illness has come together with the spread of HIV. So the World Health Organization defines two kinds of epidemics. One epidemic is a concentrated epidemic, and that's what we have here in the US and Canada. And it's an HIV prevalence of more than 5% in a specific subpopulation, but less than 1% in pregnant women. Pregnant women are used as a marker of the general population. But in a generalized epidemic, the prevalence is more than 1% among pregnant women, and that's what you see in parts of the Caribbean and in sub-Saharan Africa. So when we look at the subpopulations involved in the spread of HIV, it's men who have sex with men, injection drug users, sex workers, and partners of these groups. And all of these subgroups have elevated rates of mental illness. at-risk populations share adversities, and this is where my talk is very much in tune with what Claire Payne talked about earlier. That what you see when you look at this population is elevated rates of trauma. And that includes emotional, physical, and sexual traumas, both during childhood and in adult life. And these risk factors, these traumas are risk factors for acquiring HIV infection and developing substance use disorders and other mental illnesses, including PTSD. In HIV, we now talk about syndemics. Have you heard that term? Do you use that term? Syndemics mean epidemics that travel together and influence each other. So HIV is syndemic with substance use, it's syndemic with other mental disorders, it's syndemic with hepatitis C. It's a series of different illnesses that travel and influence one another over time. And ongoing stigma, discrimination, and legal sanctions impede access to services. Now, you here in Toronto have a very multicultural population with a lot of acceptance of different cultures. But most of the world, and we have a fair amount of that in New York, and as a Seinfeld episode once said about New York, everybody's gay. So being gay in New York is absolutely, nobody would flinch, nobody thinks anything of it. They wonder why you're not. I've had people ask me, why weren't you a lesbian? I can't really explain, because I was told that my upbringing that Mark just referred to, my pattern of early life trauma should have made me a lesbian. I don't know. So, but what we know is that in most of the world, this is not true. If you look at the southern U.S., being gay is still highly, highly stigmatized. We have an out-of-control epidemic where people cannot deal with what it means to be a gay man. To take one instance, and in Africa, of course, it's worse. In a lot of African countries, you can be sent to prison or even executed for being gay. So I try to remember that the way we experience things in our urban cultures isn't the way a lot of the world really works. The way New York City works is that we're aghast at the Republican Party and what the U.S. does. We're insane, But when you're in New York, you think, this is my country? We should probably succeed and join Canada. So, men who have sex with men have higher rates of depression, anxiety disorders, alcohol and substance use disorders, and suicide risk and attempts. Now, there is no reason at all to think that there's anything about being a gay man that should give you a higher rate of mental illness in and of itself. Most of this appears to be linked to trauma. At least that's our best guess about it. The trauma that most gay men experience in coming out, in admitting their sexuality, in the way families respond, in the way society responds, being bullied in the schoolyard. Bullying of gay youth is a big issue in the U.S. that's gotten a lot of attention. So probably, what Claire was saying is that it's probably these traumas that have resulted in elevated rates of mental illness. And as we get more and more accepting in our society of the differences among people, and hopefully we're going to continue to move in that direction, hopefully we would see these rates of mental illness go down. Basically, when it comes to injection drug users, another population which HIV has spread significantly around the world, and especially in places like Russia, about 100% of people who use drugs have a mental illness if they're injecting. First of all, close to 100% have opioid dependence, and many of them have other substance abuse problems. There's a population with high rates of early childhood adverse events, and many of them have comorbid other mental illnesses. Mood disorders and antisocial personality are the two that have been most frequently cited as non-addictive illnesses among people who inject drugs. And then we have sex workers. So I've actually done a lot of reading about the mental health of sex workers, and there's a huge literature on it. The mental health of sex workers is quite poor, especially when they do outdoor sex work versus indoor sex work. So for those of you who are unfamiliar with that, outdoor sex work is on the street. Indoor sex work is in a much more protected environment. And when you look at sex workers, they frequently have childhood histories of physical and sexual abuse. And they go on to develop high rates of substance use and dependence. And you see, and especially in the Americas, you see sex work linked to substance use quite a bit. There are people who do sex work to get substances. There are also people who use substances during sex work to make sex work more tolerable. So we see a whole range of mental illnesses among people who are engaging in sex, and they overlap quite a bit with the substance-using population. From a very early point in the epidemic in the United States, there was a study that was done. There haven't been many studies done. The interface of mental health and HIV infection has not had a lot of research done in it. And it's really, I think, one of the sad things about how the HIV epidemic in the scientific community have evolved in thinking about HIV, that largely mental illness and substance use remain the neglected stepchildren of the comorbidities of HIV. But early on, there was a study done in the U.S. of people who were HIV positive in medical care in 1996. And about 27% of them were on psychotropic medication. So that meant that 1 in every 4 people in a medical setting, this was not a psychiatric setting, were already taking a psychotropic drug, and there might have been many people who had undiagnosed mental illness. And 5% were on antipsychotics, and that was before people went crazy and started to give them to just about everybody on earth. So it made you realize that people running a medical program for HIV were seeing a lot of mental illness. I'm going to tell you a little bit. This is a little diversion about my own work. So I have worked with the severely mentally ill virtually all of my life, and the AIDS epidemic hit them early and hard in New York City, where I was running a program, and I was also functioning as the chief medical officer for the State Office of Mental Health state hospital system in New York City, which takes care of people with very chronic illness. So we were mostly seeing schizophrenia, schizoaffective disorder, bipolar disorder, mostly people who are psychotic and wind up in the public system. And I don't know to what extent you see psychosis in your HIV population. I hope to have some time for an interaction, and I'd love to find out about how it works here. So I was the chief medical officer when the first case of AIDS presented in a state hospital in New York City. It was in Brooklyn, a hospital called Kingsborough Psychiatric Center, and a woman had developed a low white blood cell count. Well, I'll get to that later because I actually have her case. But the first time AIDS appeared in a psychiatric hospital, people were absolutely hysterical. Nobody knew how it was spread. There was no antibody test. There was no household contact study. And it caused great hysteria. And it was shocking. It was just shocking. Because the first case was in a woman at a time when almost all HIV was in men. We were just completely taken aback. And then between 1985 and 87, virtually every other state hospital had a case of AIDS. And again, they were virtually all women. And generally speaking, they were initially diagnosed as having something else. So I'm just going to go through 2 of these cases. So the first was a 25-year-old woman. She developed a low white blood cell count. This was the 1983 case. And in typical fashion in psychiatric hospitals, where we barely provide adequate medical care, to be honest, it was decided that her low white blood cell count was a reaction to psychotropic medication, and nothing else was done to work her up. Not that we would have been able to test her for HIV in any case. But 8 months later, she became ill with pneumonia, and she went to the general hospital, and a biopsy of her lung showed that she had pneumocystis carinii pneumonia. Well, we called it carinii, now we call it something else. But anyway, she had pneumocystis pneumonia, and that's how we made the diagnosis of AIDS. But here's another case at one of the other psychiatric hospitals. Here was a woman, she was 34 years old, and she developed idiopathic thrombocytopenic purpura, which for those of you who aren't medical, is a low platelet count for no good reason. And then she eloped from the hospital about a year later, and she got pregnant. And she came back to the state hospital where she lived in a pregnant state. And when she had her baby, and by the time the baby came along, it was probably 1987, they tested her baby. And all babies born to HIV-positive mothers are carrying the mom's antibodies, so they don't have to be positive. And the baby was positive for antibodies. And that's how the state hospital learned that they had had this woman with HIV for years, as manifested by that blood disorder, the idiopathic thrombocytopenic purpura, which occurs in HIV. So these cases they just completely took us aback. And for those of you who've been working in HIV from the beginning of the epidemic know how shocking so much of it was in the very beginning. Now, I was working for the New York State Office of Mental Health, and their attitude toward this was let's ignore it. Now, I have to say, I don't know what agencies do in Toronto or in Canada, but mental health agencies, by and large, never think of themselves as having enough resources to take care of everything, and they're really not looking for new work. And the New York State Office of Mental Health had no desire to get itself connected with HIV. So that was the one and only time I ever got a grant from the National Institute of Mental Health, in which I was the principal investigator, to do a research project on why the patients I was seeing were developing HIV infection. Because the State Office of Mental Health refused to look at it. I said, well, if the state won't look at it, I'm going to see if the federal government, is willing to help me take a look at it. So that's how I wound up doing one of the first studies that looked at risk behavior and rates of HIV. And now there have been a lot of studies, not as many as there should be. In the U.S., in those studies that have been done, and they're not nationwide studies, they're really geographically confined to certain regions, studies have shown between 2 and 23% of people who are psychiatric patients, which is a real overestimation for the general psychiatric population. It's because of where the studies were done. But anyway, the rates were definitely elevated over the general population. And they have been almost everywhere in the world where this has been replicated, but not as dramatically as these early studies. And we learned that women were as likely to be infected as men in most places. That has held up. And that there's high rates of unsafe sexual behavior and substance use, and the likelihood of being infected with HIV as a psychiatric patient is specifically linked to what kind of drugs you're using. Because because there's a lot of comorbidity. Once you have one psychiatric illness, you're very likely to have another. You know from our diagnostic confusion that we also change the labels we give people all the time. Today you're bipolar, tomorrow you're schizoaffective, so now you have PTSD. So, we have a great problem with our labels. But in any case, once you have one psychiatric illness, you're likely to have others. And so substance use is, generally speaking, traveling with other mental illnesses. And there have been studies worldwide of psychiatric patients. Now, when I started doing this work, I was told, I was asked, psychiatric patients have sex? People were like shocked. Now, it turns out that psychiatric patients have sex, but it's not quite the same as the way the general population looks. So actually, only about half have had recent sex. You do see much higher rates of abstinence. But the sex that they're having is a lot less safe in general. And that's both because of what they're doing and the environments in which they're doing it. So that a lot of psychiatric patients are having sex, let's say, in a psychiatric hospital or a prison system, somewhere where HIV is more likely to be endemic, where you're more likely to come across a partner with HIV. And mentally ill people are more likely to have partners who they don't know well or who are in a risk group. And we also see that there's a very high rate of same-sex sexual activity, largely among people who don't identify themselves as gay or lesbian. And that's true for the men and the women, although for women it doesn't pose the same threat of HIV spread. But if you look, between 19 and 30% of severely ill psychiatric patients have had sex with someone of the same gender. And some of this occurs in single-gender settings. Reminds me a little bit, I don't know how many of you have seen the movie The Crying Game, but where basically, sex occurs, right, in a prison. Is that the one with the prison setting? Maybe I'm confusing it with another one. Yeah, where sex in prison settings, there's much more sex of men having sex with men in a prison setting in a single-gender psychiatric ward. So that's one of the reasons why those high rates exist. But the other thing is that there's a high frequency of coerced sex because it's a vulnerable group. So when you ask people, have you ever been raped? Have you ever had sex forced on you against your will? The rates are much higher than the general population. And there was a significant rate in our population, at least in New York City and some of the other populations, of people dabbling in injection drug use. They don't really look, this psychiatric population doesn't really look like the typical way you think of an injection drug user. They really look like psychiatric patients who have a history of occasionally or at one point in their lives injecting drugs. Like one of our early patients in my own program was a person who his parents both died when he was 18 and 19. He had a mother with schizophrenia who committed suicide and a father who died of alcoholism. So he'd grown up under very adverse circumstances. He had an episode of depression. In the end, his diagnosis became schizoaffective disorder, whether that was the correct diagnosis or not. But after his first hospitalization, which was for depression following the death of his second parent, he got discharged and he went to a shooting gallery. And he shot up drugs with other people for about a year, and then he stopped. And then he never did it again. And about 10 years later, he got a call from a woman he'd had sex with. And she said to him, I think you should be tested for HIV because you and I have had sex, and I don't know, whether you could have given it to me or I could have given it to you, but I have HIV. So he got tested, and in fact, he did. He had HIV. And he already had advanced infection, although he was not yet physically sick. So he didn't look like an injection drug user. He looked like a psychiatric patient, but he happened to have injected drugs, and that's what we tend to see in the severely mentally ill. And people don't pay much attention to the physical problems of severely mentally ill patients. In many settings, if you're behaving in a disturbed way, people just assume that whatever is wrong with you is mental. So you might be dying of a low blood sugar. They've even shown that if you're in a medical hospital and you have a cardiac arrest, if you are known as a mental patient, you're less likely to have the arrest team called. The level of bias against recognizing medical illness in people with mental illness is very high. And this is a population whose lifespan is 15 to 25 years shorter than the general population. So if you have schizophrenia or bipolar disorder, you're likely to live somewhere between 15 to 25 years less. There's many reasons for it, but the lack of good medical care is one of them. So getting back to the population I'm familiar with, the early group of patients died by 1996 when effective treatment came into being. All of the psychiatric patients we knew to have HIV had basically died because if there were long-term non-progressors, the people who don't, get sick, we didn't pick them up. We were only picking up sick people at a time there was no treatment. That was a phase, and I'm sure you can recollect this in Canada as well, where even before our patients began to die, some of our staff began to die. And this was largely gay men. And in my program, it was mostly, and in the state's hospital system, it was mostly psychiatrists and nurses who were gay men. And they would just kind of like disappear. It was horrible because they were largely closeted, and I don't even mean necessarily about being gay. I mean about having HIV. And that's how it was in the beginning of the epidemic. Now, one of the interesting things that happened, and maybe it's happened here, is that because the psychiatric system wasn't the least bit interested in HIV, and a funding stream to develop to take care of HIV patients in the U.S., and you can tell me a little bit about what happens here, people who had HIV who were very mentally ill, including with psychotic disorders, began to migrate into the HIV system. So when I started doing this work, most of the psychotic patients with HIV were in the mental health system. Now, that's not where they are. Almost anybody with psychosis in New York City that has HIV is in the HIV system. I have gone to programs that treat HIV patients, like day programs, where half of their patients are on antipsychotics. I don't know if they belong in them or not, but in effect, HIV programs de facto became programs that were delivering mental health services because that's where the patient went. Now, could psychotic patients take antiretrovirals? That was a big question. And I have to tell you that people with schizophrenia who aren't abusing substances and who are in treatment are very good at dealing with stigma and taking drugs that don't make them feel good. So it was actually easier in the mentally ill, severely mentally ill population to start treating HIV than it was in, let's say, the gay population, because people who were, let's say, gay professional men were shocked, in the beginning by having an illness and, were really taken aback. But our patients with schizophrenia, they were used to having a stigmatized disorder. What's more stigmatized than mental illness? They were used to us, nagging them about taking their psychotropic medicine, and psychotropic medicine doesn't feel that good. So, especially not antipsychotics. So, they actually had, in many ways, less trouble. And that's not where the adherence problems lie. The adherence problems in HIV care and treatment lie among those people who have depression and substance use disorders. That's where you see the most negative impact. So everybody talks about cascades. I tried to find one for Toronto. You may have one, but I couldn't find one. So now we're all obsessed about the fact that we want to do treatment as prevention, right? We have the idea that if we keep everybody's viral load suppressed on antiretrovirals, they won't be likely to transmit. And we do know, although we still advocate for safer sex, the fact is that if you have an undetectable viral load, it is very hard to transmit HIV. So we're trying to get everybody down there to the undetectable viral load, and we're not doing well. So this is a U.S. cascade, and it's we have about 1.2 million people with HIV, and 82% of them know they have HIV. 66% of HIV people are linked to care. Only 37% get retained in care. That's a big drop-off from linkage to retention. 33% have been prescribed antiretrovirals, and only 25% are virally suppressed. That means we're not doing well because only 1 in 4 of our HIV-positive patients, at least, that you can make criticisms of this cascade and whether they really knew exactly who was or wasn't in treatment. But still, most people with HIV are not virally suppressed. This is I found one for British Columbia cascade. And virologically suppressed is that bottom bar of light green. And it looks like in British Columbia, they're kind of doing a lot better over time, right? Getting people virally suppressed. Looks like if you look at the 2011 numbers, maybe half of people, at least in this study, had viral suppression. So why don't people? So here, you'll forgive me for just jumping. But now I'm leaving mental illness to it, and I'm going to talk a little bit about adherence because everybody's obsessed. So why don't we have good adherence? And I just want to say, long before there was ever HIV infection, people wondered why people didn't follow medical treatment. And thousands of studies has showed that whether or not people have a mental illness, it's not human nature to adhere to medical treatment. That is not what we do as people. And I love this. A long time ago, we had a Surgeon General, C. Everett Koop, who said, pills don't work if patients don't take them. That sounds like really silly. But, you know, it wasn't silly, because you can go to conferences and you can do it today, and, you know, people tell you about the latest pill, right? And they're so enamored of their pills that they talk about them in the abstract as if now we have this pill, so that solves that problem. People don't like to talk about the fact that just because you have a good pill doesn't mean people are going to take them, you know? Across diseases, whatever disease you look at, non-adherence is the primary cause of treatment failure. And there have been so many studies on adherence to medication before HIV that, you know, when there are a lot of studies, people do meta-analyses where they look at a whole bunch of studies and see what, if you look at combined studies, what does that tell you? But then there were so many meta-analyses that people began to do meta-analyses of meta-analysis. And it's sad. It's very sad what it shows. What it shows is that if you're trying to get someone to do something once, there's a lot of incentives you can use that work. But if you're trying to get someone to do something every day for years and years, virtually nothing holds up over time. Virtually nothing. The only thing that seems to have some promise is self-management. That is to say, the patient's own investment in managing their problem. And I think that's what you come to learn with any chronic disease, whether it's HIV or it's something or it's another disease, that you're really depending on getting the patient to make their own investment in staying well. So here are some of the reasons why people might not adhere. From the age of 2 on, humans perfect saying no. You know how important that is. Otherwise, how can we have any power? That Freud was right. Sex and aggression are the primary drivers of human behavior, not rational experience. Now, this matches up to the earlier talk we had. It's the lower parts of our brain that are functioning in sex as well, not our cognitive, sophisticated functions. People believe in their own theories about what's right or wrong. They may have other problems that seem to be more compelling. I once saw a patient who was bleeding from a peptic ulcer into his stomach, and I said, you have to come into the hospital because you're bleeding to death. And he said, I can't come in now. I have something important to do. What could be more important than staying alive? He said, I just can't. I just can't stay now. And he left. And that taught me very early on in my career that people have other priorities, even when they're about to die. And then it's just very difficult to be conscientious, and there's lots of reasons for that, whether it's lack of time or money or energy or a place to live or healthcare access, insurance, transportation. We can show every social variable that's associated with non-adherence, regimen complexity. People have a much easier time with 1 pill than 100 pills. And then we also have the issue of continuity. You finally come to trust a provider and the provider leaves. And provider turnover is a high time of people dropping out of care. But adherence to HIV medication is extremely important because of the reasons I just said. We're thinking about community viral load. We're thinking about suppressing the virus in the population as a whole. We're thinking about the individual not progressing. But these regimens are difficult to be adherent to because they're so chronic. And it's just difficult once you have chronic illness. And they're unforgiving in terms of how much you have to take in order to stay virally suppressed. You can't take it. There's a lot more latitude with some regimens. Like if you take antibiotics for strep throat, maybe half the pills are good enough. If you take blood pressure medicine, they estimate 80% is good enough. But we're trying to get close to 100% adherence in HIV, and that's hard. It's not human nature. So when you look at those illnesses that are mental illnesses most associated with bad outcomes, as I was saying, they're really depression and substance use, which are associated with increased morbidity and mortality, failure to start treatment, failure to adhere to treatment, and increased sexual risk behavior. And in the case of depression, the virus gets suppressed more slowly if you're depressed. There was actually a study that shows if you go for the shingles vaccine and you're depressed, it may not take. If you go for a shingles vaccine and you're depressed when you get it, it might not work. It's less likely to work. I'm going to get to this point. So, and then, in fact, I just think I'll just go on to it for the sake of time. So depression is a very common comorbidity of HIV, and it's present in 30 to 50% of people in treatment settings. It varies a lot depending on what you're calling depression, how you're defining it, how many symptoms you need to get, labeled as depressed. But the interesting thing about depression, and I, in my mind, separate it from every other mental illness. To me, severe depression is a medical illness. Yes, it affects your mind, but yes, it affects your body. And that's probably why people getting those shingle shots, when they're depressed, it's not working so well. It's really linked to your immune system in some important way. And people are beginning to understand that there's a bi-directional relationship between your immune system and how it's working, and inflammation and depression. And if you look at the symptoms of severe depression, now I'm talking about not, mild depression, you see a lot of them are physical. A lot of them have to do with disturbance in your circadian rhythms. You don't eat well. You don't sleep the way you used to. You have no energy. These are very physical manifestations. So a lot of people with depression feel very physically unwell. That's one of the reasons why they tend to present to primary care rather than psychiatrists' offices. They think maybe they're not feeling good, but mostly many of them are feeling sick. And one of the things that we've discovered about depression is that it increases the risk of dying of HIV by about twice. And it's not simply explained by non-adherence to antiretroviral medication. So I'm only going to quote two of the studies, but there's been quite a few of them. One of the early studies in the US was the HERS cohort, which showed that women with chronic depression and HIV were twice as likely to die as non-depressed women with HIV. But this was in a period of time when antiretrovirals were available. But how about in Tanzania? This was a study in Tanzania before the rollout of antiretrovirals. It followed women who were pregnant with stage 1 or 2 HIV disease, and it offered vitamin supplementation rather than antiretrovirals, which, as I say, weren't available at the time. And over the 6 to 8 years these women were followed, 31% of them died. I actually find this study kind of horrifying because really they didn't have to die if we had introduced antiretrovirals during this period. But depression was associated, independent of antiretrovirals, with a 60% increase of progressing to stage 3 and 4 HIV disease and a 2-fold greater risk of dying. So this risk of dying is independent of adherence. Non-adherence doesn't help you, but it's there even without looking at antiretrovirals. So when people go for mental health treatment, they're more likely to have good numbers in their HIV picture. So if somebody is depressed and is getting treatment, or has any mental illness, especially depression and substance use stuff, and is getting treatment, it's more likely they have a better CD4 cell count and a viral load. But we don't know why. That could just be an association that if you're willing to come for one kind of care, you're willing to come for another kind of care. If you're willing to go for your HIV treatment, you're willing to go for your mental illness treatment. But the way I like to think about it is that people with untreated mental illness, you have to think, especially when it's depression and substance use, about whether they're really taking their antiretrovirals the way they should be. There have been 2 teeny-weeny randomized controlled trials that showed when you treat depression, it doesn't automatically make people more adherent, and you need to build in an adherence mechanism. We have very little information about this topic. But I did find it very interesting that there was a recent study that was published that looked at depression in patients with cardiovascular disease. So we know that people with cardiovascular disease and depression die sooner than people who aren't depressed and have cardiovascular disease. It looks like HIV in that way. And cardiovascular disease is much more common. And there have been a series of studies done in treating people for depression with cardiovascular disease. So a recent study was published where patients were divided into two groups. They all had cardiovascular disease and they were randomly assigned to usual care, which meant that that treatment team could do whatever they normally did about the patient's depression, to a more aggressive program that really aimed to screen, diagnose, and treat depression. And what happened was that the increased mortality seen in the depressed group disappeared. They began to look like other patients with cardiovascular disease. They weren't getting more heart attacks. They weren't more likely to go into heart failure. That's the first study that actually shows that treating depression is a matter of life and death for some people. That it is a medical illness. It is a medical comorbidity. People, I hate the term behavioral health. What does it have to do with behavior? You know, I mean, true. Mental illness may manifest itself through behavior, but it really, there's no separation between in the mind and body. They're totally integrated. So this is my last slide, and I wanted to leave a little time for discussion. Do we have a little time? And this goes back to the previous talk. What allows, so I've been doing HIV and mental illness since 1983, and sometimes people say, don't you ever get tired of it? And I have never had any experience of burnout. Now, when I think about why that is, one of the, and there are many, I could tell you many reasons, but the one I really liked is the concept of the wounded healer. So this is a term that was coined by Carl Jung. And he has an essay by someone named Paul Levy elaborating on what Carl Jung said. And he said, there is a transformative and healing effect when we recognize how our individual suffering is a personalized reflection of our collective suffering. Our personal wound is the footprint and signature of the collective wound in which we all share and participate. It is liberating and healing to step out of pathologizing ourselves and recontextualize our personal conflicts, problems, and wounds as part of the wider transpersonal pattern of human experience. That's how I think of it. I came to work with disadvantaged populations because I myself was orphaned as a child. I've had various mental illnesses, which are irrelevant to this presentation. And I could always identify with other people who were in states of, who were in disadvantaged states. And I think that's what sustained me. That I wasn't only healing the people I was treating, even though they might have very different things than me. I was healing myself at the same time. There's a little bit of a paradox because, getting back to the previous speaker, depathologizing our patients, I think, is very important. And at the same time, we want to treat them for things they're suffering from if there's a treatment that works. So you wind up in a funny position where on the one hand, you want to depathologize. Like, I think of myself as pretty much a lunatic, and I feel I come by it honestly. But, for the purposes of my work life, I'm trying to depathologize it, For the purposes when I go to see a psychiatrist, no, then I can be all pathology. So, we're working with this dichotomy between our own suffering and what it's taught us and the ways in which maybe it's made us stronger, even while it's caused us to have weaknesses. And at the same time, learning how to alleviate suffering that's unnecessary. Learning how to target that part of it that could be made better when it doesn't get better on its own. So I'm going to stop there. And in the discussion, I'd be very interested to know how any of this resonates with your experience.